Today we'll be discussing breast implant choices. My name is Dr. Edward Levy, as Brianna explained. I'm a Cleveland Clinic plastic surgeon. I've been on the west side of Cleveland since 1994, previously in private practice. I operate out of Fairview Hospital. Fairview Hospital's Ambulatory Surgery Center in Westlake, and the Avon Hospital here in Avon. My office is at the Richard E. Jacobs Health Center in Avon. I'm a member of the American Society of Plastic Surgeons, and I am certified by the American Board of Plastic Surgery. So my areas of interest include a lot of breast surgery, whether it's cosmetic breast surgery for breast enlargement, breast reconstruction. We do a lot of breast reductions for patients with back, neck, shoulder pain, breast lifts, and we help patients who want their breast implants removed. I do cosmetic surgery of the face and body, as Brianna explained. In my practice, I see a lot of patients who are contemplating breast implants for one reason or another, and I frequently get the question, what is the best breast implant? Well, this is going to be a little bit difficult to answer just what is the best. There's a number of issues involved. Each patient's body characteristics will determine what implants might work better or might not work as well. Cosmetic and reconstructive patients have different needs. Certainly patients have their own preferences, and some have done a lot of research coming in to see me and have a number of specific questions. And then each surgeon that you might see will have his or her own preferences based on their experiences. There are a number of choices that we have to go through. One of the biggest ones, I would say, is the choice between a silicone or a saline-filled implant. And we'll describe each of these in a minute or two. There are smooth and textured implants. There are round implants and contoured or shaped or teardrop. There are different profiles of implants. So for a different volume of an implant, there are different degrees of width of the implant versus how far it sticks out of the projection, and we'll see pictures of that in a minute. And then size. Everybody's going to have their own personal preferences. The cosmetic patient will have their own thoughts as to what their goals are. And then the reconstructive patient, usually we're trying to match the other side, but sometimes we do have to go a little bit larger or smaller on the normal side to get reasonable symmetry. So there are four main manufacturers in the United States, four manufacturers that are FDA approved. Most common are Allergan and Mentor. Sientra would be number 3, and then there's a newer company on the market called Ideal. Allergan and Mentor have saline and silicone implants. The Sientra is just a silicone. The Allergan implants are smooth only. The Mentor and Sientra have smooth and textured implants. The Ideal is a newer implant I don't have personal experience with, that is a saline or saltwater-filled implant that has multiple shells within each other, with the idea of getting some baffling of the fluid inside the implant to make it more normal consistency, similar to what the silicone implants would provide. These are very common operations. According to the American Society of Plastic Surgeons, in 2019, there were approximately 300,000 cosmetic breast enlargements or breast augmentations performed. These are done for size preferences, but frequently also to improve the shape of the breast and repair changes that have occurred after pregnancy and nursing and with the normal aging process and possibly weight changes. There were approximately 100,000 breast reconstructive cases performed. Typically, that's for restoration of the breast after mastectomy, but frequently also to treat developmental abnormalities or asymmetries, and then also patients undergoing gender reassignment. So, looking up at the top right picture drawing, there are 3 common breast incisions. The most common one I typically use is in the crease underneath the breast, also in the junction of the areola, the colored skin, with the normal skin, and then sometimes under the axilla. There's pluses and minuses with each of these, and each surgeon will have their own preferences, and I think it depends on the patient as to, and also the implant type as to what incision would be most appropriate. So through the incision, the surgeon makes a pocket underneath the breast, and if you look at the photo on the bottom right, the implant is in a pocket that's underneath the breast tissue in yellow here. This would be a cosmetic patient. Obviously, the mastectomy patient, the breast reconstruction patient, has had the breast tissue removed. And this one is on top of the muscle. It's the pectoralis major muscle. In the photo on the right, the implant is underneath both the muscle and the breast tissue. Again, there's pluses and minuses to this. The surgeon makes a pocket for the implant. The body will develop what we call scar tissue, or a capsule, to wall off and surround the implant. Ideally, that scar tissue should stay soft and pliable. In some instances, over time, and we'll discuss later, they can get tight and firm around it. The smooth implants move within the pocket. The textured implants originally designed to adhere to the chest wall. Some do, some don't. And there's pluses and minuses to the textured implants. I used to use them when I started my practice long ago. Over the years, I've gotten away from them, and there have been some safety issues more recently with the textured implant for one of the manufacturers. So that one's not on the market anymore. The implants can be round, and also they can have a teardrop shape. Again, there's pluses and minuses to each of those. I used to use a lot of the teardrop shape implants, but over time I kind of got away from that. I prefer the round ones myself, but these are things that we can discuss. So this gives you an idea of what the implants generally look like. The upper right is a round implant. The next one down is one of those shaped or teardrop implants. So this portion here would be the lower portion, and this is the upper portion. And so it's got more of a normal shape. And when I started practice, I thought that made a lot of sense. Shortly after starting practice, I had a number of patients come into my office and said, no, I don't want that one, I want the round one. So I used a number of those, and I was impressed after surgery that it worked pretty much just as well. There are some advantages to the round implant. It's a thinner shell, and this textured implant, I think, is a little bit more noticeable. And if it gets a fold or a crease in it, it can be very noticeable. The lower two implants are both round implants. You see the round shape. The top one has a smooth surface. The bottom one has a textured surface. And again, there have been some safety concerns over one of the manufacturer's textured surface, and all of these implants are the Allergan version, and the textured implant is off the market. This one also off the market, and all of the smooth implants are round. They don't have none of the manufacturers have a round smooth implant. So looking down at the bottom, we look at the different profiles. So we'll talk about low, moderate, full profile. Allergan has actually 5 different profiles. So for a given width of the implant, you'll see some of them are fuller than others and project forth more. And so basically, we choose the width of the implant to try to go along with the patient's chest and breast width dimensions. And then we look at the profile and the projection depending on their preferences in terms of size. The implants come in cataloged by volume, and you probably can see a chart on the door behind me. That's a chart of different implant sizes and shapes. And so they would come in, let's say, 400 or 500 cc's. They don't come in cup sizes. Each implant will yield a different cup size for a patient, just depending on their personal characteristics. Someone's 5 foot 1 inches versus 6 foot 1 inches, those two implants are going to look very different. And also, if they're starting out with a B size bra to start with versus an A or a C, the final result will vary with each in the same size implant. The silicone implants are a silicone plastic shell, and they're filled with a silicone gel on the inside. This is about 85% of the market. These implants come pre-filled, so they require a slightly larger incision. And per the FDA guidance, they are available to patients 22 years or older for cosmetic purposes, and for patients undergoing breast reconstruction for whatever reason, any age, there's no requirement there. The saline-filled implants makes up the rest, and those are filled with IV fluid, the same IV fluid that goes in the vein for surgery. And this is placed via a filler tube, usually after placing the implant in the pocket, so we can get a little bit smaller incision with that. And the FDA asks that the patients be 18 years or older for that one. So I'm going to see if we can see these implants. This is a saline type implant. It's a silicone plastic shell with IV fluids on the inside. They're reasonably durable, but as we'll talk later, nothing lasts forever. This is a silicone implant, so it's just a thicker gel. It's kind of a Jell-O consistency, a little bit different than that. It holds together better than Jell-O, but it's a sticky, tacky material. The firmness of the gel implant varies with manufacturer, and also the Allergan that we've been using at the Cleveland Clinic recently has 3 different degrees of cohesiveness. Okay, the most cohesive is called the gummy bear. So the gummy bear kind of maintains its shape. What they're showing here is the implant pretty much stuck to a firm surface. It doesn't really work that way. The implant sits in a pocket, that scar tissue that the body forms around it. So the scar tissue is stuck to the chest wall or to the muscle, but the implant sits down inside that. But the gel implant, especially that cohesive gel, will maintain the upper fullness better than the saline will. This is the mid-range degree of cohesion or thickness of that gel, and this is the smoothest. And everybody's going to have their own personal preferences on this. The patients who like this one like that upper pole fullness, try to maintain that. Some people feel that doesn't maybe look quite as natural. There's a combination of things. I think all of these implants can look very natural. It's a combination of how large and just the implant. And so these are things that really the surgeon has to help the patient decide what they're going to use. The patient really can't know all the ins and outs of this, and certainly have the experience of years of doing these procedures. On the bottom right, this is the marketing material for Allergan showing their gummy bear implant. What they've done is cut it and show that thick cohesive gel stays put. It's not as firm as you would think it would be here, and in the office we have samples of each of these, and the patient can get an idea for what that feels like. What this doesn't say is what happens if an implant's leaked in that pocket and it's been there for years. Is it going to be like this, or would there be some fluid in there with it? And I think we don't really have a perfect answer for that one. I've seen it both ways, really. So how do you choose? I mean, here's the implant. Here the surgeon really needs to help this. Certainly the patient has their thoughts as to what their size preference would be. The reconstructive patient, the surgeon really needs to help choose what size would likely match the normal side best. If a patient's having mastectomy both sides, then there is some degree of leeway, but there are issues in terms of body proportions and certain patients' preferences, and also the soft tissue coverage. You can only go so big without it looking like an implant and showing some potential problems with it. So good communication between the patient and the surgeon is necessary to make those decisions. Again, the profile we discussed before, whether it's a low, moderate, or high profile implant, just depending on the patient's chest and breast width and the size preference. The shape, the round versus contoured. My preference these days is the round implant. I would say that doesn't necessarily have to be an exclusive thing, but I think it really works very well. And I think that some of the problems that I've seen with the contoured implants are not as frequent with the round. That surface, the textured versus smooth, the round implants can be obtained both ways. The teardrop shape implant does have a textured surface to try to get it from rotating or going into an improper position, although they don't always stick to the chest wall, which is fine. The textured surface years ago was developed to try to decrease the likelihood or the tendency of that scar tissue from getting very tight around the implant. In certain circumstances, that seemed to help, especially if the implant was on top of the muscle. Underneath the muscle doesn't seem to be as much of an issue. The textured surface we'll talk about in a little bit as to why we don't use that now. So here's some issues. This patient has had bilateral, means both sides, mastectomy. So there's no significant, breast tissue overlying these implants, and she's thin, so there's little soft tissue coverage. So this is a patient, you can see the rippling and the wrinkling, which some of these implants are prone to. Now, we showed before, just below in the implant pictures, the implant kind of hanging from the chest wall. And again, the implant's not hanging, that scar tissue is hanging, and the implant's sitting down into it. A saline implant will not hold its upper pole shape and fullness very well. And so this sort of problem can come up and be more noticeable with the saline implant. The silicone implant, especially the cohesive one, will tend to fill this better and make this less noticeable. Now, having said that, this is something that's obviously a major issue for this patient. A bra will help support it and make that easier to hide. But this, I should also say, this is not a real frequent problem, at least to this degree. We'll see little bits of it, and there's some other things that we can try to do. And then everybody's going to have their own thoughts in terms of the softness or the firmness of the implant and the shape of the breast. Next question is longevity. How long do these last? We got numbers and studies that the manufacturers came up with. I think they're okay studies. They're not great. Bottom line is what I tell patients, a ballpark figure is about 1% per year failure rate with any implant, which means that at 10 years, 90% of implants are still okay. There are some that would leak prior to that. Some patients say they've been on the internet, they've read that you should replace your implants every 10 years or 12 years or whatever. And I can't argue 100% against that. My personal inclination is if it ain't broke, don't fix it, because it is surgery that you may or may not need. And there is potential risk with any surgery. So the saline implants, you'll know when they leak, your body absorbs the fluid, they'll get small. That can be very inconvenient, depending on exactly when that happens. The silicone implants, you probably won't know when they leak. That gel could get into surrounding tissues, but it's unlikely. Most of the time it remains within that scar tissue capsule that the body forms around the implant. And so most of the time the patient won't even know that it's leaked. And I think people are going to argue whether that's a significant safety issue or not. We certainly do recommend removing a leaked implant and most of the time replace it or whatever the patient prefers. But the only good way of telling whether the silicone implants have leaked is by an MRI. Well, if it's a breast reconstruction patient, usually that's covered by insurance. If it's cosmetic, the patient's paying out of pocket for that, and it's very pricey. So that can be a significant issue also. But bottom line is about 85% of the market is the silicone implant. It's been the most popular and very high patient satisfaction with that. In my practice, it's not quite 50-50, but I do a lot more saline than the average, and that's because I really discuss these things with my patients and help them decide what they're comfortable with. The incisions we briefly mentioned, the silicone implants require a bigger incision. I like that lower incision in the crease for the silicone implants, especially. The other ones, you're really having to push and distort things more to get them in. The silicone implants will be a little bit more expensive, and there's always going to be some controversy over these implants. Overall, I'm very comfortable with them, but there will be things that come up in the news as to, are they causing health issues or not? And what I tell patients is that, you've got to be comfortable with it. If you're going to worry about it, it's not worth worrying about. So go with whatever you're comfortable with. I'm comfortable with all of them, but it's obviously not something that I've got to live with. Just to show some patients who've been through this. Now, patients will come in sometimes and they'll say, well, I want my breast very firm and natural. And that's great, but what we can accomplish depends on where we start. So this upper patient here has very good skin elasticity, not much sagging, and so on the left is before and the right is after she's had the cosmetic breast enlargement through the incisions in the crease underneath. She has very little sagging. Some people might say, well, it's a little lower than I want. But the thing is, her breasts were a little lower than, somebody else's to start with. And so we're really putting the implant behind the breast. If I put the implants up higher, it gives better upper pole fullness. But now the nipple is going to be very low on the implant. That's not going to look right. The other thing is some people say, oh, I don't want a gap between. This patient doesn't have much of a gap between, but again, where she started determines where she ends up with it. The lower patient has some sagging. She's had a couple of kids, and so she's starting out with a little bit of sagging, and she, after discussion, decided to just have the implants alone. And you could decide whether you think there's some sagging or not with this. The implants have really filled things out. She's very happy with the results of this. We could do a little bit of a lift with her, not a very aggressive lift, but we could do a little bit of a lift, but that adds extra scars around the nipple and the areola and then down to the crease underneath. Sometimes the lift, if it's a significant amount, also includes an incision, a long incision underneath. So for this patient, this really, just enlargement alone was the way to go with her. So the patients want fuller and improved shape, a natural appearance. We want good symmetry, minimal scars. We want the implants to not be very noticeable. And so this is where the silicone probably does a little bit better than the saline. I think that smooth implant does better than the textured implant, which is firmer. And then we'd like it to be normal sensation and ability to breastfeed or nurse. These are good goals. I can't guarantee that we're going to accomplish all these things, but this is certainly what we're striving for. So limitations, again, the results are dependent on where we started. Size, big implants going to potentially cause bigger problems. They may be more noticeable. The other thing is, if a patient has them removed in the future, how much of a change has that created to the breast? Now, there's things that we can do to try to correct for that, and we can't make every decision, based on what could happen someday. I mean, most patients are very happy with the breast enlargement. I'm a little conservative. I don't have patients for the cosmetic purposes with large implants. The largest implants that I see are for patients who have breast reconstruction, and typically those patients have a large breast and may be heavier to start with. The lift procedure may be necessary to get the shape the patient wants. We can't do a real strong lift at the same time as putting the breast implants in. That can increase the complications. And then we discussed the breast and nipple position and cleavage, the incisions and scars. There will be some, and just what we end up having to do, whether just the augmentation or the lift procedures will determine that. Some patients do come in with photos that they've downloaded or seen in a magazine or something like that, and it's helpful to see that to some degree, because I can understand what the patient is looking for, and then I can help discuss what our possibilities are and what we can and can't accomplish. Pros and cons, we discussed the size and the shape, the texture, on top of the muscle or underneath the muscle. So traditionally speaking, the underneath the muscle gives additional coverage. The downside is when the patient uses that muscle, pulls or pushes with the arms, the implant could move back and forth with it. It's not damaging to the implant, but it could be somewhat noticeable. For the breast reconstruction patient, that can be more noticeable issues, and we discussed that during our consultations. And then the silicone and saline issues we've discussed. And then that cohesive implant is a little firmer, has a little better shape and holds its shape, but it may be a little bit firmer, more noticeable. So these patients don't need implant slide. The patient top right, young patient, not much sagging, just large breasts and uncomfortable with that. She had a breast reduction. I've had patients come in who say, well, take out the breast tissue and just put implants in so things will be firmer. I don't recommend doing that. I think if the patient's uncomfortable with the size of the breast, we should do a breast reduction. We do a lift along with that, and that will help lift the breast. It doesn't determine exactly the size and the shape, but it really is very helpful, and you don't have the long-term issues of having to deal with implants. This particular patient has a scar around the nipple areola and then down to the crease underneath. The patient bottom left has a lot of sagging, and her issue was not so much the volume of the breast. She actually was happy with the size of the breast in a bra. It was really the shape. And so she had a breast lift just to correct the shape. She did not have implants. So again, her scar is here and then down, and she did require the incision in the crease underneath because of the degree of skin that we had to remove. The patient on the right has breast implants on the left photo, and she came in. She had implants for quite a long time. The implants were a little high. So here's a patient who has implants that are a little high, and we talked about having them a little too high because the nipple is down a little lower and just a little bit below where the fullness of the center of the breast mound is. She came in because she had developed a lot of swelling around the left implant, which is one of the things that can happen when an implant leaks. And she had silicone implants, and she just said, you know what, take them out. I'm done with them. I had them for years. I loved them. Just take them out. And so that's what we did, and she ended up looking on the right. And she has a fairly normal appearance on the right, certainly, not, the aesthetic ideal, but this is kind of where she probably would have ended up, or close to where she would have ended up with, and she never had implants anyways. So breast reconstruction, just a different group of patients in requirements, especially for the patients after mastectomy. The goals here typically are symmetry. We'd like that implant and the reconstruction to remain soft. The challenge is they have less soft tissue coverage, which can be an issue in terms of that patient that we saw earlier with the rippling and wrinkling. There can be other soft tissue deficiencies and cognitive abnormalities that we need to address. Patients who have been through radiation can develop more problems in terms of the tightening of that scar tissue. And then the other thing is we're trying to match an implant to a normal breast. So these patients have had mastectomy, and they've had their implants in. These particular patients have not had nipple reconstruction. That's something that we do fairly frequently, and then some patients are candidates for nipple-sparing mastectomy. So the patient on the top left has had the mastectomy and implant reconstruction. She actually has an implant on the left side also, and so we got pretty good symmetry with her. The patient in the middle, larger breast, she had some sagging, and so we had to do a lift procedure for her. And so again, the nipple areola incision and down to the crease, and then side to side the crease underneath. She had a very good contour as a result. They're not always going to be like this, but she had good symmetry, and that worked out well for her. Patient on the left, much larger, and did require a breast reduction. And so the patients I showed down below, just to kind of show you, the upper patients are the contours that we typically get with breast reconstruction. But if the patient's got a lot of sagging, as the patient on the bottom left, now this patient was in for breast reduction. She does not have cancer, but the implant's not going to match that. And so the breast reduction procedure is going to really help with that. And so the patient bottom left has had the breast reduction. That shows you the before and afters. The patient bottom right has a lot of sagging. She's, again, not unhappy with the volume of the breast, just wants things lifted. Again, discussing where the breast ends up is based on where the breast starts. And if you look at hers, she's got a low crease on the chest wall, and so that ends up being the same location, but we reshape the breast and do the lift. She also had contouring of the arms. She had lost a lot of weight. So the long-term results, number one, there's very high satisfaction rate with the implants, but we do tell people that this is not necessarily a one-time procedure. There is some maintenance with the implants, and that could be revisions. It could be removal of the implant with or without replacement. If you look at the statistics for how many patients need reoperation, some of them need additional surgery for coincidental sort of thing that's not necessarily implant related, but we do expect some maintenance. We do expect over time that the implant will probably leak, and we can't tell you, just when that'll be. Unfortunately, I've seen patients who have had implants for 30 years, and I've seen patients who have had a leak after 6 or 8 years, and the short term is pretty unusual. Why do implants leak? Well, over time, what I typically see is either mechanically parts kind of pulling apart a little bit, or a valve leaking, but more frequently just fatigue of the plastic, just developing a crack in the shell of the implant with movement. We talked about the silicone being contained within that scar tissue. That's what we would expect. I have seen some patients occasionally where the silicone is outside of the scar tissue. The old implants that were taken off the market back in 1992 due to concerns were a much thinner, runnier gel than today's. So we're much more comfortable with today's implant. Other reasons for additional surgery: that scar tissue that normally forms around the pocket of the implant in some patients will get tight. It can be very firm, cause the implant to look misshapen. It can be painful. And so those are patients that sometimes need to have revision surgery. Patients may change their mind in terms of size and want to go larger. So those are in the statistics. Malposition, or things just not looking right, or symmetry, pain, breast changes with the aging process, could look better. Rippling and wrinkling, we mentioned, scar problems. There are a number of other reasons for reoperation down the list a bit. Now, this is more the fine print of what we really need to go through with patients. Other risks of any of the breast surgery, and especially the cosmetic breast patients, is numbness or hypersensitivity, too sensitive. So the breast reconstruction patients frequently will have numbness of the breast as a result of mastectomy, and so the implant reconstruction does not fix that. Can patients breastfeed? The cosmetic patients breastfeed after breast augmentation. I'd say frequently that works out, and we would expect it to, and we would encourage patients to go ahead with that. But it's not going to work out for everybody. There are some patients who can have some other problems. Infection can require the removal of an implant sometimes to get the infection cured, and then swelling and fluid collections occur sometimes. So surgical risk right off the, out of surgery, always a risk of bleeding, infection, wound healing problems, anesthesia risk of being asleep for general anesthesia. And then the other thing that's come up over the last, probably initially identified maybe about 20 years ago, but it's hit the news and hit our literature in the last 10 years, and has hit the news the last few years several times, and will come up probably again, is a form of lymphoma occurring at the breast implant. So lymphoma is a blood cell or immune cell cancer, and these are tumors that occur at the breast implant. So this has been associated with that textured surface implant, specifically a very rough textured surface implant, and so that one was removed from the market. The risk is still very small. There's been somewhere on the order of 700 or 800 case reports of it, but it's a real thing, and we think that it's a good idea to not use that particular textured implant. Can I say the other manufacturers' textured implants are immune to that? I can't say that, but there's less concern. And then the other thing that's come up and is more in the news, I would say, recently, is what is called breast implant illness. And so this, breast implants have had controversy around them since they came out in the 60s. In 1992, the FDA pulled the silicone off the cosmetic market because of concerns. Looking back statistically, we have not been able to show that it's causing this. There are some questions and some concerns with it, and we're still looking for more and more data and information with it. It's going to be a long time before we have that. So I do see some patients who come in who want their implants out. They've got fatigue and muscle and joint aches and pains and weakness and a number of other things that they're concerned with. And so they often want their implants out with that. And these are things that occur frequently in the normal population. So the statistics aren't really going to tell us, number one, if the implants are causing that, and number two, whether we take the implants out is going to fix those problems or not. So these are things we're going to continue looking out for. But again, with the number of patients that we're seeing with breast implants on a yearly basis, the satisfaction level has been very high with it. I think it's important that we continue to try to follow and make sure things are as safe as they can be. I'd say getting an implant is kind of like getting a tattoo. There's potential risks and issues with tattoos. There's patients who have significant allergies to them and have to have tattoos removed, which can be very deforming to scar with that. And so you know, these are personal preferences and things that patients need to consider, and the surgeon needs to discuss with the patient. Patients should not have implants if they have active infection, if they have cancer that has not been adequately addressed or treated, or if they're pregnant or nursing. There are patients who are at higher risk for having problems. That doesn't mean they can't have the implants, but we need to consider these. So things that affect wound healing, such as diabetes or connective tissue disorders. Smokers are at higher risk for it. There are medications that affect or impair the immune system. Our breast reconstruction patients are at a bit higher risk of having problems with their chemotherapy and radiation. And then conditions that affect wound healing or blood clotting. So there are a number of different things. And then what's not been studied, what's been excluded from the studies, or patients with autoimmune disease or family history of autoimmune disease. So this is one of those things that comes up with the patients wanting their implants removed. Is there an autoimmune issue? And so these patients were excluded from the original studies. And again, we just don't have good statistics on all of these things. So a couple of other things here, but these are the main issues, and so we're happy to help out with it. We see a lot of patients with this. I think the consultation is very important with the surgeon. A patient come in should have a full list of questions, and we should go through that. And frequently, it's helpful to have a second consult to go over all the questions. And so at this point, I will end my talk and we'll leave it up to questions.
Thank you so much, Dr. Levy, for that informative presentation. So again, for anyone who has joined us, please feel free to write your questions in the chat, and then I will read them to Dr. Levy. We've actually received a question or two prior to this. So the first question is, what is your opinion about fat transfer to increase breast size or fullness in a natural breast?
So I'm on the conservative side, and I can't say it doesn't work. And we do fat transfers for some of our breast reconstruction patients. The concern has been, and I've discussed it with some of our own radiologists, is that the fat transfer can leave some spots on the mammogram, little oil cysts or some calcifications. Now, the people who do the fat transfers, and some do a lot of it, will argue that the radiologists are able to tell the difference between changes due to the fat transfer versus the things that we look for with breast cancer. But my concern is that if we're causing changes in a mammogram, is it making it hard to read that mammogram and pick up some very subtle findings that might be visible without the fat transfer in the way, but might be missed with the fat transfer. Now, having said that, I would say that breast augmentation or breast implants do get in the way of mammogram to some degree also. And the patients, when they have mammograms, it's now called a diagnostic mammogram. You have to let the facility know that you've got the breast implants, and they have to do things a little differently.
Great. Thank you for making us aware of that kind of outcome or potential outcome. Our next question is just, could you clarify the age restrictions? I think you mentioned them earlier, but could you clarify?
Right. So there's silicone and saline filled implants, and for the saline filled implants, the FDA says for cosmetic purposes. I'm kind of getting another call here, so I don't know if this is going to knock me off. Let's give it a try, anyways. For cosmetic purposes, can you still hear me, Brianna?
We can. It goes out. So we'll give it a couple of seconds. Just let them finish calling.
Yeah, I'll just let this quit ringing. Yep. How about now? Am I better?
Yep, you're good to go.
Okay. So for cosmetic purposes, the FDA says 22 years of age or older. And for the silicone implants, for the saline implants, 18 years or older. And for the silicone implants, 22 years or older for cosmetic purposes. For breast reconstruction, there's no age restriction.
Thank you. And then can you talk a little bit about how long surgery will take and the recovery time?
So the cosmetic breast enlargement, I would say for a very basic, just putting an implant in, no other procedure associated with it, is probably going to take about an hour to hour and a half of general anesthesia. Obviously, I have to add some time getting in and out of surgery and asleep, but hour and a half. The breast reconstructions vary quite a bit, just depending on what all needs to be done, and there's a lot more work going on than just the insertion of the implant.
Got it. And then did you mention recovery time?
I'm sorry. What I tell people is for the cosmetic reconstruction, for the cosmetic purposes, to plan on at least a long weekend to get back to a desk job. If they're pretty active at work, probably about 10 days will get them back to a lot of things. But if it's strenuous sorts of things, especially using upper extremity, it can be a few weeks. The breast reconstruction patients typically have more leeway in terms of jobs and such and getting back to things. For those patients, I do recommend taking it very easy for about 3 weeks. And then we slowly get back into activities. Most of the patients, by 6 or 8 weeks after surgery, they can be back to doing pretty much everything. Heavy exercise, low impact, I recommend about 6 weeks. For anything goes, including running, where there's going to be a lot of pulling and tugging on the implants and the incisions, I usually recommend at least 8 weeks.
Thank you so much, Dr. Levy. All right, it doesn't look like we have any additional questions in the chat. So we'll go ahead and close out. I want to thank you again for taking your time to share this information with our guests, and thank you everyone for joining us.